So, the white matter diseases, these are the ones which I always found challenging. And often you end up in a dilemma. Often we end up with more than one diagnosis. And usually these are the cases when you call your friend, when you speak to your colleagues. So another thing is, it will be very hard. It will be very hard for any person to know everything. And also, it will be almost, I won't say impossible, but often the diseases, they do not follow what they're expected to do. So they are uncommon presentations of the common one. At the same time, they're the common presentation of the uncommon pathologies. So that's why, it's better to work as a team, to speak to each other, in particular with the clinicians. So we'll go through what can be the important bits in the history, which we need to know. And if there's nothing in the history, and if it's a complex case, then one must pick the phone and speak to the clinician. And nothing can replace a good history. In particular, we can ask, like any co-ops, in particular, if they're on, if they've got any malignancy, if they are on chemotherapy / if they're immunocompromised, if they had some prodromal symptoms like runny nose or sore throat before they had the symptoms. So, all those things, better to speak to them. And often talking to them for, yeah, it might take few minutes, but it will save a lot more time for you and it will be good for the patient. And then we'll go through how to look at these. And tensor imaging, I will not go into that detail, it's on the horizon. And then just we'll go through these at the end. So no conflict of interest. And as said before, history, we must not ignore. And it's not only a problem here, but every part of the world. It's not uncommon that forms might be filled by the most junior person of the team, who may not know the importance of those relevant parts. So don't be shy, don't be reluctant to speak to the senior person of the team. And often, um, they will welcome you. And similarly, we will welcome any clinician coming to us. So it will make a difference. So white matter, what are they? So basically, these are like connecting wires. So they are the connecting wires. The gray matter, they are the processors, and the white matter are the connecting them. So there can be different fibers. So there can be different channels, different wires connecting different bits from each other. So there can be projection fibers, which are the most commonly known, like corticospinal tract, cerebellospinal tract, or corticothalamic tract. So all these, they are connecting gray matter further down, either connecting to the gray matter of the thalamus or even further down into the spinal cord. So these are the going downward, in other words. Then there are fibers which are like circuits on any motherboard of the computer, which are connecting the processors of the computer to each other. So these are the fibers which are within the cortex. These are within the cortex. So that's one explanation, that when subsequently we'll talk about the location of the white matter, gray matter, that why sometimes in the white matter diseases, we do see altered signal, altered, um, the changes or images within the gray matter as well. So even if it's a gray matter, but still it does contain some white fibers. And then there are commissure fibers, which pass through the corpus callosum. Right talks to left, left talks to right. And so it is a lot more complex. And another schematic diagram where we can see the fibers. So we all know, so that's the cortex. And then these are the projection fibers going down. These are the commissural. And then these are again the projection to the white matter, to the spinal cord. These talking to each other. And then there are the fibers between the gray parts as well. So usually, I will say, the cortex is at the periphery, white matter in the center. But then again, we have got further gray matter nuclei like thalamus, hypothalamus, caudate nucleus, and then in the brainstem we talk about the red nucleus and further. T2, which we also call sometimes like false image, white is not white, gray is not gray. So the gray matter out there and the one which is like dark, these are the tracks. So we can see them going across. So these are the white matter. So these are the tracks. Very familiar for all of us, this image. And so this is the tensor imaging picture. So we can see which fibers are running in which direction. And very important when the surgeons, they're planning to take any part, that which other parts of the brain will be affected. And it's also telling that, especially if we look at the projection fibers, that how the corticospinal tract is extending, at what level we can expect it to lie, which part of the brain. So we can see even here in the midbrain, it lies anteriorly. So we should know where we are expecting to see the pathology. A picture of at the midbrain level. So these are the again the white matter, the corticospinal tract, crus cerebri, and then behind this, that's the gray matter. And then again the red nuclei, as the name says, this is a gray matter. So when we are looking at that, we are picking a hyperintense focus, the typical T2 FLAIR hyperintense focus, that where it is. Is this right at anteriorly, sorry, which is the white matter, or is it in the substantia nigra area, which will be like this gray part? So we should know our anatomy. And if we know our anatomy, we can get close to the pathology. So now we'll crack on the white matter disorder. So we can broadly divide the white matters in three groups. The one we commonly come across, demyelinating. And if you ask any radiology trainee, usually, the MS is the one which will stand out and everyone will talk about it, our favorite. And yes, along MS, we can talk about ATOM, we can talk about multifocal diseases. And then we come across the dysmyelinating, in which is destroyed. So it is not the inflammatory process, but it is the other metabolic or other causes which are resulting in destruction of the white fibers. And even the dysmyelinating can be divided into congenital or acquired. And then the hypomyelinating, yes, myelin is there, the white matter is there, but not as much as we want. So taking into account of how much time we have got, I think we can cross hereditary disorder. That's a huge discussion on its own. Same, we can leave hypomyelinating disorder for another day. So we will go through demyelinating diseases and dysmyelinating diseases. Especially these are the ones we commonly come across. So we'll start with the demyelinating disorder. We'll start the one which we most come across. And the residents in particular, uh, they're very keen to know more about it. And multiple sclerosis, it is probably more common than we think. If I will just recall, practice of a single institute, usually we do see probably one case a week, among the new um, patients. So one case a week, that's very significant, very significant. So again, so we can go through it. So we know, so just like, disease process anywhere in the body, same principle applies here. Whenever we look at the image, whenever we look at the pathology, always ask yourself, where is the epicenter? Where is the epicenter? And often it will take us to the diagnosis. So epicenter is the key in radiology overall. So if you look at here, so I've just, all these images, I put them here so we can see that's a textbook picture, dorsal fingers, corpus callosal involvement, and we know There's no gray matter in the corpus callosum. So here, and so we can see the subtle high T2 signal within the cord, and here in the corona radiata. And on T1, as these are like plaques or edematous changes, so they may look like, we call them holes. So it will be signal white on T1 weighted sequence. So that's a textbook picture of the multiple sclerosis. But as I said before, not all the patients, not all the diseases go through the textbooks before they come to hospital. So we all should be prepared to look for the atypical presentation, early presentation, and especially, it's not uncommon, especially in our practice where the primary physician or the neurology setup is patchy. Often these patients may have some treatment, often incomplete, of these diseases. So that's why these could be like partly treated or treated for something else. They might have steroids for some other reason. So we may not see the typical picture. And whenever we see the multiple sclerosis, apart from looking at what do we expect, always also look what complications can arise from that one. Always think a step further. So it can give rise to PML, like more aggressive form, and it can turn into, I won't say turn into, but the incidence of lymphoma is high in the plaques. So whenever we are looking at it, and if they're progressing, apart from progressive demyelinating disease, think, could this be lymphoma? So another thing we should think about. And just like inflammatory condition, it can give rise to vasculitis and stroke as well. So all these things, whenever we're looking at it, think about it. And MOGART is it's another syndrome when we get antibodies, the phosphate, I always forget its a typical name, MEPO phosphate antibodies, some four antibodies. So when we're looking at MS, do not forget outside the brain. Yes, we're looking at the cord, but also look at the orbits. Look at the optic nerve. If the optic nerve gets involved, yes, there's a possibility. And then we do get the antibodies, and then there's a different criteria. If the antibodies are positive, what else we want to label it for MOGOD? And if they're not, then what criteria we want? And I said before, there's a lot to learn for all of us, a lot to learn. And we do not come across these cases often. So don't be shy of opening the books, checking the literature, and reading those things again and again. It's better to read. Often, whenever we read, we come across something new, and to give the patient better, precise report than wishy-washy report. Another thing which we all come across and we all heard, and often a favorite exam question as well, Adam, and which is usually post-viral. Patients do have like flu, fever, and from few days to few weeks, patients will come with the central symptoms. Usually it's the autoantibodies, vasculitis, and it can, depending upon what was the primary virus, we can have huge variation of the presentation. But usually it's much more aggressive form, and the typical is that usually it does not involve corpus callosum. But I said usually, so often it does not. And so we can see here it's the typical white matter. So we can see as I said in the beginning, the epicenter is the white center. Always look where's the epicenter. Corpus callosum is not affected. And if you look at the influenza, and if you look at so this is post-influenza. So if you look at it, it is a textbook picture. I got it from radiographics. It is a thalamus. And if we just recall our initial presentation, that's a gray matter. So why did we get this one involved in a leukodystrophy? So the fibers come there. So there is overlapping there as well. So even if it is going into gray matter area, especially into central one, or sometimes When it is involving the U fibers, it can involve opaline cortex as well. Do not get it out of differential completely. Yes, we may bring it a bit higher or lower, but do not exclude it completely, please. And when it gets really worse, then we may get hemorrhagic atom as well. And yes, the T2 star is over front here. It's much more aggressive. And especially many of these cases we came across were during COVID. Another one, we see the typical multifocal one, in the white matter, subcortical, corticospinal tract, white matter. Another one, it is a PML. So as such, as the name says, progressive. So often in these patients, it will be difficult to give it a typical name. Have a low threshold for repeat imaging at a short interval, how the disease is behaving. Follow-up, short-term follow-up is the key. So again, we can see on CT how it will look like. So the key is we can see the cortex is relatively preserved. It is a white matter. It is the white matter problem. And now moving to from inflammatory to the leukodystrophic, the metabolic one. So we'll just fly through it. So in this one, it is not the autoimmune, it is some systemic problem which is giving rise to these problems. Again, history is important. What toxins, what metabolites the patient will be exposed to. For example, if patient came with a hypoglycemic shock, we know the cortex or all the gray matter involves it. So yes, that will be area. So yeah, it was a history, very hypoglycemic patient. And if we all know with the hyponatremia, rapid correction, we get periaqueductal gray matter changes. Carbon monoxide, if it was from part of the world where it was cold, unburned gas, the coals were inside the room, or the gas unfortunately turned off and then on again. Typical basal ganglion side part. Thank you. Huge variety of things can cause it, huge. So whenever there's a story, I think it's better just to look at it, and the internet is our friend, to be honest. So much there, so much. So it's always okay. What other people have found, where my picture matches with others, and we must find it. Methanol, typical. So all those changes. Follow up. So yes, it's improving. Deflagell or metronidazole toxicity, another one. So we can say cyclosporins or chemotherapy induced leukodystrophy, that's very thing which we come across here almost every other week. And here often the question is it disease involvement or is it the treatment related? Treatment is different. Should we stop the treatment or should we continue it? So one should be careful, and often the key is close follow-up and CSF analysis and the distribution and what the disease is. What chemotherapeutic agents the patient is on, always explore those. Cyclosporins, methotrexate, they have got a typical pattern. Explore it, find it. Stopped it, and we can see it got better. Methotrexate, bilateral symmetrical. So with the metabolic, often it's a bilateral symmetrical pattern we see. So typically involves the U fibers. So in summary, nothing can replace a good history. If it's not there, yes, leave the room, pick the phone, find the history, speak to the clinician. All the clinicians, they like it. And then again, it's a systematic approach. Where's the epicenter? And think whether it's a gray matter or white matter. But again, it's a very, very blurred line. So if it's involving any the thalamus or part of the cortex, do not throw the white matter disorder out of window. Sometimes it can involve, especially the areas which were within it. And DTI, yes, we are working on it, and have a low threshold to repeat the imaging. Yeah, thank you. Any questions?
I have a couple of questions and one comment. Number one, NMO spectrum rather than but I don't know the reason. NMO spectrum rather than one land in the world. Number two, you said, I'm sorry, and number two, you said that MS can be converted to lymphoma or ADEM. So I'm just curious that, are there any case reports or because, I'm sorry,
Yeah.
I'm just,
Yeah, definitely the risk of lymphoma is higher in the patient with MS when they get the plaques. And if we look at the literature, when we talk about the complication, there's a lot written on it in the radiology and radiographics article. So there is definite evidence. So there were some papers with some evidence. I don't remember the exact authors, but
Okay.
it was definitely, that was a source.
Okay.
And in terms of ADAM, when there is one pathological process going on, just imagine what is the MS? It's inflammatory. And what is the ADAM? It's again inflammatory. So if our immune system is triggered already once, and if you come across a viral infection, we are more likely to trigger that system again. So another viral infection can either result in flare up of MS or it can fall into that category. The underlying process is same, the inflammatory demyelinating condition.
I'm sorry, I was talking about PML, progressive
PML, yeah.
PML, yes. So I was talking about that. So that itself inherently MS cannot be converted to PML until unless a person is taking some big guns like immunosuppressant therapies,
Yes.
then the chances of JC are more higher in those. Like, but if multiple sclerosis itself, it does not change into PML.
No, thanks
Yeah.
for correcting. And
Yeah, that's what
yes,
one thing. Yeah.
that is definitely, especially in the literature, they mentioned about few medications, and usually if you get the PML, it is a few weeks after they discontinue those medicines. So that's why, yeah, history is important.
Right.
And after, you're right, it's the whole chapter, whole world, these things. It's
Yeah.
very difficult to cover it in 20 minutes.
Yeah,
So
thank you for clarifying. And one more last comment was NMO spectrum disorder was also, it is a big kind of part
Completely.
that was not covered. Yeah. Where it's the longest longitudinal segment, like more than 2 to 3, spinal segments. So that was because this was a more demyelinating talk. So I think that was missing in this, but hopefully
That's-
next time.
Yeah, thank you.
you.